So that's why AARP Foundation has started fighting back with people on behalf of some of our most vulnerable clients. And we started doing this really at a National Consumer Voice Conference. Actually, I was speaking at the conference in maybe 2011 and saying we've got to find cases. We need to, I mean, it's great that we're doing so much legislative advocacy, but we actually need to sue people and try to really start catalyzing the change we want to see. So, stepping back for a second, I want to tell you a little bit about who AARP Foundation Litigation is. The AARP Foundation is the charitable arm of AARP. We are the litigation arm. We're a small but mighty force of attorneys who work within AARP Foundation, headed by Bill Rivera. And we do a series of different kinds of litigation on behalf of low-income people who are vulnerable in any number of ways. Today, I'm just going to talk to you about the work that Iris and Mommy and I and others have done in our office on behalf of people who are basically being restrained against their will and against the knowledge of their families. And it's very shocking when families discover this, and that's part of why we've become so committed to doing this, because the families are devastated by when they discover that this has happened to their family members. But pause for a moment to think of all the people who don't have the family members. We have amazing clients who have stepped forward and have been advocates for their family. And those are the people that we've been able to represent, but there are so many countless invisible people, as we have on our sheet, that are not getting representation. Their voice is not being heard. No one is even noticing that they're on these drugs. And they didn't consent. They sometimes mostly aren't even capable of giving the consent. But so then you look at the situation for Bob's family or Robin's family, and they are the legally authorized people. They went to all the trouble of getting the powers of attorney. They became the medical representatives, and even they were not consulted. So this is a problem that has so many different permutations, and the hook that we put into it, because we needed a legal hook as lawyers, was the informed consent piece. But I can tell you that there are three kind of major themes that have emerged for us as we've done these cases. The first is that this is not a treatment. And you'll hear from Dr. Evans, who and all of our experts have educated us so much that there is no treatment benefit for people with dementia to getting these drugs. So it's not even a panacea. It's actually dangerous. So it's not just to make you feel better if you're doing something, as Dr. Evans, I'm going to steal your line, Jonathan, every nail is something to be hammered down. It's not a problem that needs a hammer. It's a problem that needs a treatment. And so a lot of the things are very simple behaviors that our clients have manifested that led to this. In our case that we had in California, was a woman who was in a nursing facility in Ventura County for 18 days. And in those 18 days, she went from 2 medications upon admission to 11 by the 17th day. And why? What was the behavior that was so troubling? She had broken her hip, so they had her basically tied to the wheelchair to try to keep her, and she kept shifting because she was uncomfortable. But she wasn't able to say, I'm uncomfortable. So instead, they said, well, she's obviously, there's a problem here. We need to give her some pain medicines. So they'd start with the pain medicines. The next day, I read through all these records, page by page. The next day, the nurse calls the doctor. Pain medicines aren't working. Give her some Zyprexa. Okay. Next day, that Zyprexa didn't work. It's one day. I want to see maybe something else, maybe Zoloft. What could we layer on? So they layered day after day after day all these drugs to this woman, and her mother was the legal guardian, and they never once, not one time, picked up the phone to either say we need to get your consent, or very importantly, to tell her there's a change in status. I mean, if a person in a nursing facility experiences a change in medical status, the regulations are not equivocal. You must contact the family, you must tell them what's going on, and you must try to come up with a plan. And the family knows the person better than anybody in that facility. The family is going to say, oh, when she does that when she's uncomfortable, sometimes she's going to yell out, and that's going to be her thing. But she's trying to explain to you, you're just being too thick to hear what she's telling you. But she actually is communicating something to you. So this is that's one of the important things we discovered. And again, that ties to the second thing we discovered, which is these are rarely given with meaningful informed consent. And how do we know that? Not just because people who are guardians don't get asked, but we also know that because what would an informed consent conversation look like with a black box warning drug? I want to give your mom a drug that says right on the label that if I give it to a person with dementia who's elderly, it could kill her. Are you okay with that? That is the informed consent conversation you would have to have. And it's really, she doesn't need it. She doesn't have a diagnosis that supports it, but it would certainly make our lives easier at the facility because we didn't staff up properly. So this is literally the meaningful conversation you would have to get families to say, sure, that sounds fantastic. Give her 2. I mean, this is part of why we know that can't be happening, because no family would agree to that. And then again, you step back and think, okay, there are all these other people who also don't have powers of attorney, don't have legal authority, responsible people in their lives, and they're just getting it without anybody even questioning. So why do we care so much about these drugs? These are drugs that you hear about every day, drugs like risperidol, Zyprexa, Seroquel, Abilify, Geodon. These are drugs that you hear about. But why is it so deadly that they are given to people with dementia? It's because they literally stop their functioning, they stop their cognitive abilities, they can stop their heart, they can give them pneumonia, they can cause falls. But before they do all of that, they cause them to lose the ability to swallow or to eat, or the failure to thrive is a word you hear in nursing facilities, as though it's their fault that they've failed to thrive. But they're failing to thrive because they're being chemically restrained. And those things then spiral out of control to other consequences. And so in our cases, we've seen this time and time again, not just in the cases we've done. We've interviewed hundreds of families because they've come to us with their stories. Hundreds of people have repeated these exact same stories. And so, our mighty team of 3, we're bringing the cases we can bring, but we have to continue to bring them. And so the cases that we are seeing are are shocking because people are dying. That's shocking. But it's how they're dying. They're dying terrible, painful deaths. And in a way, and this is part of the difficulty, I heard one of my clients saying that, that she was wondering if she'd ever be able to find representation. The difficulty is our clients are 94, 95, 96 years old. Private attorneys aren't clamoring to represent them, because they say, this person was going to die anyway. But we're all going to die anyway. That doesn't mean that anybody should be robbed of one day of meaningful life or dignity or their health for one day unnecessarily. And that's what these drugs do. They're stealing people's lives unnecessarily. And that's why they are called unnecessary drugs. So I want to take a minute and give you a chance to talk to my client, Bob, about his mom. Bob's case we brought in about 3 years ago. We started it 3 years ago, right? We met you 3 years ago. We met him because he had read about as with Robin, read about our work in the Levine case.
Either way, it's fine. Does this work? First off, I'd like to thank Kelly, Mommy, the whole AARP team for the support over the past few years, and also for supporting this forum. This is, very personal to me. I mean, for most of you, except for Robin and her family, it's, you see it, but I lived through it, and it's horrible what's going on out there. In my mother, Sylvia Pierce, her specific case, knew when she came in that she had dementia. I'm sorry, let me know if it's not coming through. And also that my sister and I were her legal health care proxies. It was in the admission, et cetera. Well, soon after she was admitted, within a week, she complained about discomfort, pain. The staff at the facility said she was yelling out, as I think is typical when you're in discomfort, in pain. So. And without our knowledge, they immediately put her on a drug regimen, which included one antipsychotic and some other drugs as a chemical restraint without our knowledge. soon after, this is all within a couple of weeks, 3 weeks maybe, I visited her, and she was lethargic, severe decline in both physical and mental health. And so we asked for a care plan meeting, okay? And so when we had the care plan meeting, that's when we were informed of this drug regimen, and that one of the drugs was Zyprexa. We were kind of, in a daze, a little bit shocked, didn't really understand. They didn't explain anything about what Zyprexa was. So we said, well, we need to think this over, look at it, research it to some extent. And, it didn't take long. As soon as you type in Zyprexa to Google and elderly, the first thing that jumps up is, as I think Lisa mentioned, the black box warning. And and I think as Kelly mentioned, how are you going to sell that to a patient that this could kill your mother? So after that, we did research and we requested that my mother be safely taken off this drug regimen. And as I mentioned, it was a regimen. It also included 2 antidepressants. And this is all within maybe a 4-week time frame of when she was admitted to the facility. So they did take her off the regimen, but she passed away soon after. Obviously, we had a lot of questions and a lot of doubts as to what was going on with her treatment, and we requested the state of Delaware to do an investigation. Well, they did, and the investigator did a really great job, deemed to have 3 major violations, and I think they've all been discussed, that there was no informed consent, lack of informed consent, that there was no care plan put together for my mother's treatment, and the unnecessary drugs. But unfortunately, even though I think Bethany, maybe you mentioned monetary fines, et cetera, nothing. It was basically a promise that they'll try to do better next time. And so during this time, as Kelly mentioned, this whole thing wasn't sufficient, in terms of accountability. So I did contact Kelly based on the California case, and it's been 3+ years now, and we are looking to drive change and not only change but accountability. And because I think until there is accountability, there's not going to be change. So.
Thank you, Bob. Thank you for sharing that story. One thing that I wanted to add, the third piece that is consistent across all the cases we've done, is the failure to monitor. So these drugs have known side effects. So you would think that people would be watching for the known side effects, and yet they don't. Rarely do you find documentation that they're looking for tremors and shuffling and difficulty swallowing, all the things that are actually indicative of a problem that the label itself warns the doctors and treatment staff about, that is rarely seen in any of the records that we have found. And that, to me, is maybe one of that's all horrible and sad, but that to me is the most unforgivable thing, because how could you possibly put somebody into a dangerous situation knowingly and then just turn your back and not even wait to see? Sometimes, as you saw, Bethany, in your report, sometimes you can reverse the damage of these drugs, sometimes. And sometimes you absolutely cannot. And so especially when you have a frail older person, the studies that you referred to that led to the black box warning, those were studies on 65-year-olds. When you're dealing with 85-year-olds, imagine the complexity of the damage that is being done to them, or if they're already compromised with a hospital stay for some other problem. So part of the third piece of these cases that we've been bringing is we are suing not just on the drugs, but on the failure to really focus in on what is what have we done? You cannot just turn your back. It's almost an ageist idea that, well, whatever we do, que sera, sera. You know, they're in the nursing home. We literally had a nursing home witness tell us once, well, they signed a consent to come in here. I'm like, what does that have to do with anything? Well, they signed a consent. That means that any treatment that happens here, they consented to that. And this is the pervasive, really insurmountable, not insurmountable, because we're going to surmount it. This is the pervasive, really difficult problem, though, that I think we have to focus on with culture change.